Today's webinar is Understanding Selective Mutism, and our presenter is Dr. Courtney Keaton. Dr. Keaton is a licensed psychologist and assistant professor of psychiatry and behavioral sciences at Johns Hopkins. She received her undergraduate degree in psychology from Duke University and a doctorate in clinical psychology from the University of Massachusetts, Amherst. Her training also included a pre-doctoral internship at the Duke University Medical Center, followed by a postdoctoral fellowship at Johns Hopkins. She now splits her time between research and clinical work. At the Johns Hopkins School of Medicine, she works on a number of research studies focused on interventions for child mental health and has published scientific articles and book chapters on the topic of anxiety disorders and selective mutism. Dr. Keaton also has an outpatient clinic at the Johns Hopkins University Hospital, where it specializes in the behavioral treatment of selective mutism. So I'm going to welcome Dr. Keaton.
Thank you, Carol. I'll go ahead and get started here and move past the title slide. And first, just review the topics that I'm aiming to address this afternoon. The first goal I have is to make a distinction between selective mutism and shyness. And then I'm going to talk about the course of selective mutism. Does it go away over time, or is treatment actually needed? And what are the behavioral treatments for selective mutism? The role of the school in treatment? What actions should be considered? And also some considerations for parents out there who have a child with selective mutism or think they have a child with selective mutism, and what sorts of things might they keep in mind. I start off with just going over the formal definition of selective mutism, which is a consistent failure to speak in social situations when speaking is expected, despite showing the capacity for age-appropriate speech in other situations. And those situations are usually where the child is most comfortable, such as at home with immediate family members. The lack of speech is in other situations, most typically at school or public situations like playgrounds, in malls, or in restaurants. The lack of speech goes beyond mere shyness, though these kids are quite shy. Difference is that shy kids can still function adequately and get their needs met, whereas with selective mutism don't speak many times when they need to speak to get their needs met, and this is what is disabling about the condition. So let me share some examples. I treated one 5-year-old who had fallen and fractured his arm on the playground during recess at school, and this was in the middle of the day. He did not report the incident or his pain to anyone, and he got home at the end of the day and reported it to his parents, at which point we were able to take him for an X-ray and verify the fracture. A child who is shy would speak up in that type of situation. As another example from this current school year, I have a first grader who I treat, and she was inadvertently put on the wrong school bus on the first day of school, and she could not communicate this problem to the bus driver. A shy child, however, would find a way to communicate a problem of that severity. In less dramatic examples, I've seen many kids who just don't feel well at school, and they might cry or show some sort of distress, but can't communicate to the teacher or school nurse what exactly the problem is, and it results in a bit of a guessing game. So kids who are just shy are able to get those kinds of needs met without getting caught in such tricky situations. The lack of speech diagnosis, usually you have to have a set of symptoms, and the symptoms have to be causing some impairment in one's life, in their functioning. So the lack of speaking in this case interferes most prominently with academic and social functioning. So with regard to school functioning, these kids may be fluent in the classroom, but typically they're well-behaved, cooperative, and attentive to the curriculum. So interference with academic functioning may not be readily recognized by some. But children who don't speak in the classroom can't ask questions or seek help when they don't understand something, participate in cooperative learning tasks. Their lack of speech makes it challenging for a teacher to assess their knowledge, which becomes more and more problematic over time as academic demands increase. On a social level, a lack of speech interferes with a child's ability to form friendships and to practice and master appropriate language and social skills, which are one of their primary tasks of development as young children. So, from a clinical standpoint, these kids are typically very well liked by other kids, and they're even often looked out for. Kids sort of take care of them after recognizing that they don't speak up for themselves. But their lack of speech does put them in a vulnerable position and can create situations where these kids are targeted by bullies because of an ability to speak up for themselves and defend themselves. There's also a duration criterion for selective mutism in that the refusal to speak has to be going on for at least a 1-month period, and there's a caveat that 1 month cannot be the first month of school. And that is because a brief refusal to speak isn't necessarily uncommon in children. There's a number of normally developing children who do show some degree of reticence in new social situations and even develop transient mutism during transitional periods, like the beginning of the school year. So this isn't a problem that we would really diagnose if it's just spontaneously showed up during those first several weeks of school. Moving on to this next slide, there's historically been some debate about how to best conceptualize selective mutism, but there is now a general consensus in the field that it's a form of anxiety. Specifically, many understand selective mutism as a developmental expression of social phobia, which is also called social anxiety disorder. And this is characterized by anxiety about situations involving other people, so that the person is worried about being humiliated or embarrassed, and as a result experiences a high degree of distress and avoidance in these situations. And as it turns out, a high degree of children with SM also meet criteria for social phobia, meaning that they not only withhold speech, but they fail to participate, avoid social opportunities, or they freeze up physically in social situations like birthday parties, playing with other kids on the playground, participating on a team sport, performing school play, and a number of other situations. There are children, especially the younger ones, who do only show characteristics of selective mutism, and they still continue to engage fully in social activities, but it's just on a nonverbal level. But more often than not, especially with increasing age, selective mutism and social phobia tend to go hand in hand. So in recognition of this, we're on our way as a field to incorporating selective mutism as part of the formal social anxiety disorder diagnosis, rather than as a distinct disorder as it is currently defined. So what you see on your screen is this DSM-4-TR. This is the Diagnostic and Statistical Manual of Mental Disorders, and this is the book we all use. It contains any formal diagnosis under the umbrella of mental health that exists out there. And so if a child right now is going to be diagnosed, they would get this label of selective mutism. However, in the coming year, we have a revision of the DSM coming out, and this is where selective mutism is going to be reclassified and considered a specifier of social anxiety disorder. So this speaks to our increased understanding of selective mutism as a social anxiety disorder.
Interesting.
Okay, let me move on to just talk a little bit more about what we see, because the trickiest thing about selective mutism, especially relative to other troubles that we see clinically, is that there's such a large range of variation in terms of how these children present, how they look when we lay our eyes on them. It's a very heterogeneous problem. There's no clear profile that a child would match up with in order to sort of clearly meet the diagnostic criteria. So what we see is a lot of variation in terms of speech behaviors by context. So some kids, most typically, if I were a fly on the wall at home, I'd see them just like any other kid. They'd be narrating their play, starting conversations, asking questions. They'd be arguing with parents, starting fights with siblings. They would just have all sorts of things to say. In contrast, there would be a discrepancy in what you see in other situations where they'd freeze up and maybe be entirely quiet in a different context, like school, which is a very social situation. But there's such variation in what you see. So at home, it might be dependent on who exactly is around. And in school, some kids completely clam up upon entering the school premises, whereas others are okay until they actually enter their specific classroom. Some kids might be okay in the cafeteria or on the playground, but not in other areas of the school. So it's not so black and white in terms of what you see in terms of speech behaviors based on context, and there's just a lot of variation. There's variation for people, too, in terms of the quality and quantity of speech that's demonstrated by these children. So they might be much more comfortable with immediate family member and perhaps some other relatives and friends, but not parents of their friends or not siblings of their friends. Some kids are actually more willing to let their voice be heard if it's around people who they don't know, strangers, but they are more inclined to withhold their speech around people who they are familiar with, like classmates. I also see a lot of variability in the degree of nonverbal features that we see. So some kids, are completely comfortable communicating in nonverbal ways, gestures, eye contact, nods, whereas other kids, their lack of speech or their lack of communication even extends to nonverbal communication, where they might completely freeze up and not be responsive at all in terms of eye contact or giving nods for answering yes or no, for example. We also see variation in terms of features of their speaking, and so some kids sort of guise their voice and will use a baby talk voice, for example, in some situations. Others might be okay whispering but not talking in a regular volume. Others are okay actually maybe answering some questions with one or two words, but they just don't show the full range of speech in terms of spontaneous speech, like actually holding a conversation or reciprocating a question with a question back to another person. So there's just a huge degree of variation, just both within and across children when it comes to the clinical presentation of selective mutism. This next slide shows some information about how common the problem is and some information about gender and age of onset. So, in general, the numbers that I follow are about 1 out of every 140 kids would meet criteria for selective mutism. Depending on the source you're looking at, you're going to see differences in those rates. The prevalence varies, and this is because studies vary in terms of the methods used, such as the populations sampled or the definition of the problem. So the prevalence of 0.7% is based on studies conducted here in the United States within the past 10 years, and they're based on community samples. What's interesting about this is that selective mutism is considered a relatively rare problem, but in fact, these numbers show that it's comparable to other emotional or behavioral problems that we are much more familiar with, like obsessive-compulsive disorder, for example. In terms of gender, sources that you might pick up or read about online or articles that you might get a hold of suggest that selective mutism occurs slightly more frequently in girls compared to boys, but there are several studies showing equal rates across gender. So I would say that whether or not there's a gender difference is pretty debatable. However, since we consider it an anxiety disorder overall in the class of anxiety disorders, there's a bit of a gender difference with girls or women showing higher rates, slightly over boys or men. And so you see why that shows up in some studies, that there's this gender difference. In terms of onset, selective mutism begins in the preschool age years, before age 5 in over 80% of cases. The symptoms are likely to become more apparent during school age because that's when children face greater pressure to speak with teachers and friends. In general, school is the first setting where the symptoms are first identified because there are signs of impairment due to lack of speech, even if the behavior was evident prior to school entry. But usually what happens is the child might be considered shy for a number of years, and then it's not until they're in school where it's, oh, okay, this is becoming a problem. So what ends up happening is that the onset usually occurs prior to age 5, but then kids don't usually show up in treatment until later, between 6.5 and 9 years of age is sort of the window of time that we most commonly see kids presenting for treatment. This slide is about the course. What do we know about what happens with selective mutism over time? A common misperception is that children will outgrow the problem, but this is unfortunately not the case for most kids. Instead, selective mutism tends to follow a chronic course, which is consistent with other anxiety disorders. We know from follow-up studies of treated individuals and retrospective reports from individuals who recall selective mutism as trend, that the course of the disorder continues over time or presents as social anxiety, even if the selective mutism piece resolves. The breakdown that we have from one follow-up study showed that about 1/3 of all individuals were all better over time, 1/3 significantly improved compared to baseline, and 1/3 were not much better. So even when speaking is no longer a problem, many individuals are bothered by continued symptoms of social phobia, they have social skills deficits, or even other symptoms like problems with mood, for example, depression. We know from treatment studies that the age of onset and duration of symptoms are good predictors of treatment effect size, so specifically younger age and a shorter duration of symptoms are associated with better outcomes, basically, larger treatment effects. And part of that is because the longer a behavior exists, like mutism, the more often it's reinforced, and so the harder it is to extinguish and change. So it's a plug for early intervention, basically. Okay, so this slide, etiology, is what are the causal factors? This helps us think about who is at risk. Fortunately, like with many problems, there isn't a black and white answer with regard to what explains the problem happened. You know, where did this come from? Really what it is it's more likely than not a combination of a number of variables, and it's nearly impossible to tease apart for any given individual. But what we have is a lot of evidence for likely risk factors. So one is a familial or genetic component. Data showing that up to 80% first-degree relatives of children with selective mutism, personal history of social anxiety or extreme shyness. There's a high rate of avoidant personality disorder and lifetime generalized social phobia among parents of children with selective mutism compared to parents of children without any disorder. From two studies that between 30 and 40% of first-degree relatives of children with selective mutism have a personal history of selective mutism. So what this is saying is that, like other forms of anxiety, congregates within families. There's also a temperament component. So if you get to talk to parents and have them describe their kids with selective mutism, they describe their kids as always having been shy, withdrawn, slow to warm up to new or social situations. And there's a specific type of temperament called behavioral inhibition that is characterized by a reluctance to speak, responding well to new situations, or handling transitions poorly. So parents' descriptions of their children with selective mutism match these characteristics of behavioral inhibition. And behavioral inhibition is associated with an increased risk for future anxiety disorder, specifically social anxiety disorder. So it doesn't mean that children who are behaviorally inhibited will become increasingly anxious by any means. It's a common thread, children who end up being characterized as anxious. So it's just another one of those risk factors. There's also environmental vulnerabilities. So one thing, the families of children with selective mutism tend to be just less socially active in general compared to of children who don't have selective mutism. We also see some differences in certain parenting behaviors. So parents of children with selective mutism, in general, on average, exhibit an increased frequency of behaviors that can limit independence. So it might be defined as over-controlling or accommodating behavior, sort of stepping in and doing things for a child rather than seeing them complete tasks on their own or more independently. And then the last piece that fits under this category is that the lack of speech that characterizes selective mutism is thought to be a result of negatively reinforced behavior. So for one thing, if you have a child who doesn't speak, and this is a pattern, then what happens is there are less requests to speak. And this sort of feeds into a cycle. So a child who doesn't speak and having people who don't then require that child to speak, and that keeps the problem going. The second way this happens is there's a removal of anxiety as a consequence of withholding speech. So let's say somebody asks the child a question, the child stays quiet, and then they feel better. They don't have this high feeling of distress or anxiety, and so they go, woo, stable it there, this works. I'm going to keep not talking because it feels a lot better. So those patterns reinforce the lack of speech over time. I do want to make another point that there is little evidence that selective mutism is a product of a traumatic experience. Existing data highly supports that there's a more gradual onset. So that's not to say that there aren't cases where a child experiences something traumatic, and part of their response is to withhold speech, but that's not what the story usually is with selective mutism. So it's incorrect to assume that if a child doesn't speak, for example, that they must have been sexually abused, for example. That's just unlikely to be the case. What are some other things that sort of hang with with selective mutism? Primarily, it's not uncommon to see other forms of anxiety. I already have mentioned that social phobia is a common one. We see rates of separation anxiety disorder, specific phobias, generalized anxiety, or just worry, or also just physical symptoms, which in general are a red flag for anxiety disorder. So a lot of stomach discomfort, headaches, that sort of thing. It's not common to see elimination problems such as constipation, enuresis, which is involuntary urination, or capricis, which is an inability to control the elimination of stool. And we also see some oppositional behavior. Now, that's not to be confused with the definition of selective mutism, because in general, these kids very much want to be talking, and they often intend to talk, but something happens and it gets sabotaged. They go to talk and it just doesn't come out. They're not making, for the most part, they're not making a willful decision to speak because they're going to be difficult or something. But they might show some behaviors that appear oppositional because they have really high anxiety. So They might be refusing to do something, throwing a tantrum, but not being able to articulate that it's because they're highly anxious about the situation, and so they appear oppositional. Kids who get formal diagnoses of sort of disruptive behavior disorder show more outright defiance, arguing, purposefully annoying others. We do sort of have a subset of kids we see with selective mutism who do meet that sort of profile, but not all of them by any means. I also do see some kids who have other forms of communication problems. There is some data, for example, that some children with selective mutism compared to other children have more difficulty with articulation or expressive language. Okay, so this slide is assessment. So if a parent has concerns, the first step would be to have the child evaluated by a qualified professional who could determine if a diagnosis of selective mutism is warranted, and also to rule out other explanations of symptoms and to find out what other types of symptoms might be present. This first step is necessary because it's always the assessment that dictates what makes sense for treatment. The assessment typically includes collection of information through a number of different methods. One is observational. So, for example, one of the tricky parts about evaluating a child who doesn't talk, if they come to my office, is that they're unlikely to talk to me. So what I have families do is bring me an audio recording or video recording from home or wherever the child is most comfortable and they're being sort of their true self. And I can view that as evidence that this does have the capacity for age-appropriate speech, and I can use that to help rule out other explanations of the lack of speech, such as a communication disorder. Other observational methods include observing the child in the classroom, because it allows someone to pick up perhaps on some details others might not even think to report. It just doesn't occur to them. So that's observational methods, and then we also, so there's interviewing, and evaluation most typically includes sitting down with the family and going over a clinical interview where a lot of information about the history and course of the symptoms are reported, and the interviewer can collect information about other possible symptoms, just as a verbal report from parents. We have a lot of questionnaires where parents or teachers can fill out rating scales, for example, to provide some information on child's symptoms. And these can usually be scored in such a way that you can determine if the score is, for example, elevated compared to where you'd see the average child. And then other times, a speech and language assessment is a good idea with these kids, particularly if it's questionable about whether there are any kind of communication delays present, either apart from the selective mutism or in addition to it. This next slide is get treatment. So in general, we can boil treatment down to psychosocial treatment and pharmacological treatment, or on-medication versus medication treatment. Regardless of the treatment type, the goals usually very similar. They include reducing anxiety, increasing the quality and quantity of speech across people and situations, and ultimately achieve remission. So there's a difference between a child who is significantly improved over time and a child who is symptom-free, and they are no different than every other child in their classroom, for example. And so remission would be that they show spontaneous, age-appropriate conversational speech across contexts. You can imagine then is that it could take quite some time to see that degree of change, to go from significantly impaired to a point of remission. I'm going to talk first and mostly about psychosocial treatment. There's a lot of forms of medication treatment options out there, and there are plenty of case reports or case studies that show that these various forms of treatment can be very helpful. The most data that we have is focused on behavioral and cognitive behavioral approaches. So as a result, there is consensus in the field. The standard of care basically is to consider cognitive behavioral approaches as your first line approach. That's the first step to take. And so that's what I'm going to focus on. What we see here is sort of a picture of cognitive behavioral perspective. So we have these four bubbles: physiology, emotions, cognition, and behavior. And what we think is that a person's unique physiology, emotional functioning, behavior tendencies, and cognitive patterns occur within a context that is unique to that person. So when a child is evaluated, and we're doing an assessment and developing a treatment plan, our job is to consider that child's personal circumstances. As a cognitive behavioral therapist, our job is to intervene at the cognitive behavioral levels to influence the larger picture. Our job is to influence thinking, acting, feeling, and bodily reaction patterns. That's sort of the theory, but what are the features of cognitive behavioral therapy? Well, for one thing, it's a time-limited treatment. So this means that somebody shouldn't be in treatment for life. The reason for that is that it's based on learning a set of skills to target specific problems, and it's goal-driven. So there are goals that are usually defined but by the family and the treating clinician, and so there's skills that are targeting those specific problems in order to meet those goals. The idea is to learn and practice them in the context of treatment, but then to take them out and generalize that to the person's real world, their real life, and to continue to exercise those skills and use them so that the treatment is no longer needed, but someone's lifestyle and habits have changed. I did just say time limited, but with selective mutism, the course of treatment does tend to be longer than for other problems, other forms of anxiety. It's a tougher problem to crack, and there's a long way to go from lack of speech to age-appropriate speech. CBT is structured therapy. It's present and solution-focused. So what that means is that appreciation for history and of what's happened in the past. But we don't spend too much time worrying about what happened in the past or trying to speculate what led to the problem. Instead, we're focused on, well, the problem exists, and it's an issue. People are concerned about it, so let's do something about it. Moving forward, we want to sort of stop the symptoms from continuing to escalate into the future. Another feature is that this is a collective treatment. So what that means is that the family and the child and the clinician are working together on a team where the clinician is playing more of a coaching role. So everyone decide together what it is they're working on, and a lot of cues have to be taken from the child so treatment can progress at a rate that is acceptable to the child and that feels okay. And another important feature is that it's empirically based, which means that we have data to support that a reasonable number of children should actually respond to this type of treatment. So if I have these bubbles back up here, and they're more, before it was just general CBT. So I've changed what's inside these circles a little bit. So rather than emotion, I have anxiety there, and rather than what I have before cognition, I have anxious belief, and so forth. So what this is some of the things that interact together to produce the problem, and what this means is, treatment perspective, is that we target each of these, knowing that there's an interaction among them. So if you target one, then theoretically it should really change the interaction of all of these components at once. So, for example, with the anxiety bubble, we focus on education, so in teaching the family and the child about anxiety, about helpful adaptive anxiety, and the unhelpful kind that gets in the way. We teach about our body's physiological response, or clues that our body gives us that lets us know that we're experiencing distress or anxiety in a situation, and there are some things we can do about that. So, for example, we might teach a series of relaxation skills to target the physiology. Circle, anxious beliefs, recognizes that anyone who is anxious tends to have a set of thoughts that that anxiety. They're usually irrational or distorted, worried thoughts. So sort of expecting that the worst will happen, or anticipating a negative outcome when there's really little data to support that a negative outcome will occur in a situation. And finally, there's this green circle, which is the behavior circle. Lots of different types of behavior that contribute to the presentation of selective mutism. So one is avoidant behavior, which is the avoidance of speech, primarily. There's the accommodation by others. I'm going to talk a little bit more about that in a second. And there may or may not be some parenting behaviors that usually inadvertently might be keeping the problem going. So these arrows pointing to the circles are saying, like, this is our point of intervention, that we have certain skills that we might teach to manage any of these categories. What I focus on is the green circle, the behavioral piece, because especially, well, for selective mutism in general, and especially for the younger kids, this is where I find one of the more important pieces, where you really need to work hard in order to experience some change. And so I'm going to go through each of these three categories of behavior individually to talk about the treatment. So we'll talk about avoidant behavior, accommodation by others, and parenting. So this one is targeting avoidant behavior. And the techniques that are used, which you may or may not have heard of, are graduated exposure, shaping, or stimulus fading. These are some of the terms that really describe how we overcome avoidant behavior, and we do that by teaching and reinforcing approach behaviors, but do it in a gradual way that feels reasonable for a child. You have a child who's not talking and you want them to talk. It feels like an impossible task because we cannot make somebody talk. What we can do is figure out the smallest steps that we can take to start to chip away at the problem, with the ultimate goal to have the child talking. But we just have to be patient and figure out what steps that child is willing and able to take. So what you see here is a picture that looks sort of like steps or stairs. And exactly what it is. This is called a gradual hierarchy. So this is something I might create here in my office. If I have a child who's not talking and my goal is to get them to talk to me, then we need to figure out where we can start. And so one place we might start is for that child to sit with me while I watch a video that they've brought from home where a child is talking. Because for most kids, it's a lot less anxiety-provoking for me to see that on a video rather than having them do it live. So that might be a first step, and then we might move up from there to mapping, for example. And we do this in ways that make it fun and engaging for the child. So that means that we might do it in the context of a game. Really, the ultimate task is that the child is communicating in a way that is qualitatively a step forward compared to where they were. So we might play a game and the task would be to mouth themes of pictures or colors in the game. And then from there we'd move to whispering. So if we're playing Chutes and Ladders, for example, and they spin a 4, then they have to whisper 1, 2, 3, 4 when they're moving their piece along the board. And they might move to asking questions during a game. So a good game for staging that is Guess Who, when the goal of the game is to ask questions in order to narrow down who the opponent is. And we move from there to actually reading a short story aloud. So you can see this is an example of moving from not talking to talking, but in a step-by-step way. So in the course of treatment, what I usually have are multiple hierarchies like this, and we do some in session, and then we might have some for in school, and other ones for in public places. So we have to sort of target the different contexts where there is a lack of speech. This slide is for accommodation by other people. So, for example, one of the things that we all tend to do is this some of us call mind reading. Especially if it's your child. Let's say you know your child better than anyone else, and you just know what they're thinking or based on their body or their facial expressions. And so you naturally respond to that. So you might see what they're doing and say, oh, you need to go potty, let's go get to the bathroom. So one of the things that we target is trying to do less of that. Even when you know what's going on, our goal is to encourage the child to use more words. So rather than predicting what's going on for them, even when you know, you would just say, what's going on? What do you need? Getting them to first practice verbalizing things starting in low-stress situations. Like you obviously can't do that when you're out in public surrounded by a number of people who they talk in front of. So we usually start that step at home or while visiting the school when the other students are not present, for example. Another tip to keep in mind is giving a child a chance to respond before repeating a question. So another thing that we all just tend to do, just by habit, is we repeat the question because we're uncomfortable with silence. So I ask a child a question like, what's the name of school you go to again? Most parents just spontaneously look at their child and then say, oh, what's the name of your school? And then the child, doesn't answer because then they've heard 2 questions, and then it's even more anxiety-provoking. So we practice waiting and being comfortable with silence for 3 to 5 full seconds. Because a lot of times kids are just needing some time to work up the courage to spit out the answer that they're formulating in their mind. The other thing is that we focus on creating more opportunities for speech. So we have to be really mindful, like if you're out and about in public, what can you do to encourage just a bit of speech, even if it's one little word? So it might be like you're paying in line at Target, and the cashier's right there, and then you say, like, you wanted some gum, right? What flavor gum did you want? I'll grab it. And the child has to say, blue or whatever, and the idea is that they're practicing doing that in front of the cashier. But they wouldn't do that if you're not sort of constantly being mindful on a daily basis of creating these opportunities for practice. And then another tip that we target is staying involved in social activities. So a lot of parents understandably are protective of their kids because they're reading their kids' cues and they're sort of thinking like, no, they're miserable when we sign them up for T-ball or they want to go to this birthday party. It's no fun for them, and so then they don't do it. But what we encourage is the opposite. Even if it's difficult, we have to do it because not doing it doesn't help it at all. And so we sort of have to get over the hump of avoiding things by sort of just sucking it up and doing it, but picking things that seem most doable. The next slide is targeting parenting parenting behaviors. For one thing, we encourage increased structure and routine in the home if that's something that could be improved. And this is because most anxious children respond much better when there's predictability and a routine in place, because they have increased anxiety when they don't know what's happening next and caught off guard, or they have to make transitions between one thing and the next. And so we focus on how can we create some additional routine for them at home. We focus on how can we encourage more independence in the child. So are there any things that we're sort of doing for that child that we could reasonably expect that child to be doing on his or her own, because we want to encourage increased independence and autonomy. Talk about how to best offer praise and rewards for the behaviors that we want to see more of, like speaking. And we talk about increasing a child's control during play by narrating, which is also as opposed to asking a lot of questions. So when we play with kids, it's only natural to do things like, oh, and what's that you're drawing, and what are you going to do next, and come over here, oh, what are you building? And we ask a lot of questions. And we've learned from various research studies that it's actually really helpful for kids to hold off on that questioning and to instead be more of an observer, or more like a narrator of their play, to show you're paying attention and interested, but you're not killing the behavior by asking questions, and you're not putting increased pressure on them or heightening their anxiety by asking questions. Those are some examples of some of the things we do to target parenting behavior so that parents can be an active part of the treatment. This one is intervening at the school level. School participation is very important in the treatment of selective mutism. And so for one thing, it's really essential to collect some teacher feedback about how the child is functioning in the classroom. It's really useful to schools if we can provide some education to them. They may or may not have experienced selective mutism. They have some inaccurate thoughts about what it is, and others have lots of experience with it. So we always just offer some education so they feel like they have more of an understanding of what it is and what they can do about it. Sometimes kids are eligible for services through an individualized education plan or Section 504 plan, and it varies depending on what's going on with the child. But most importantly, it's helpful to see how willing and able a teacher is to participate in the treatment as one of the collaborative partners, and to help define and measure some daily speech goals. One of the things that I find important is to use something called a daily report card. So that's what you see here on the slide. This is for a child who's doing pretty well in the treatment. But what we might do is just create some goals for that child to accomplish each day. A teacher just looks for whether or not the goals are satisfied, and then marks on the card, yes, it happened, or no, it didn't. So this is constructed in this way so as not to take up too much time on the part of a teacher, but it facilitates the parent-teacher communication, and it's a way to really measure a child's success and progress, and it helps figure out, are these goals reasonable, or are they maybe too challenging? Getting to the end here, because I realize we're getting short on time, and I need to leave some time for questions. So quickly, with regard to medication treatment, this is recommended when the interventions that I just discussed are ineffective, or symptoms are chronic and severe. The first-line class of medications are called selective serotonin reuptake inhibitors, and some examples of these are fluoxetine, sertraline, and paroxetine. These are also known as Prozac, Zoloft, and Paxil. These ones are the ones that are up here because we have the most data to support. They're tolerated by kids, even young kids, and can be really helpful, especially in terms of reducing anxiety. Okay, so I'm returning now to those original questions that I had up in the beginning, and I'm going to open up for some questions. is selective mutism just shyness? Hopefully what I've conveyed is that it's more than shyness. Formal diagnosis suggests a problem that has been ongoing in numerous situations, and it's causing a problem. And just shyness doesn't really cause problems of that degree. My child has selective mutism. Is treatment needed? Well, the majority of cases don't tend to resolve without intervention. And in cases when the selective mutism does go away, there is a high risk that anxiety persists in some form or another. So that suggests that treatment would be helpful, if anything, to monitor what other symptoms of anxiety may be present. Why are behavioral interventions recommended? Well, selective mutism is maintained by avoidant behavior, and data suggests that it can be effectively treated by learning healthy coping and approach behaviors in a gradual way. Does the school need to be involved? Schools typically where the symptoms are most severe, so that means interventions need to be applied in the school setting. Treatment tends to be most successful when school staff are aware of the problem and part of the treatment collaboration. Should medication be considered? This suggests that SSRIs are well tolerated and effective in child populations, and medications should be considered in treatment-resistant cases, like you've tried other forms of treatment and you've gotten nowhere, when symptoms are severe, or when additional anxiety or other problems exist. And finally, how do I effectively parent my child with selective mutism? Be her biggest advocate. Understand that selective mutism is not a voluntary phenomenon and that progress is gradual. Collaborate with your child to make a plan and praise brave speech and independent behavior. And here's my contact information. That's it for my presentation. I'm happy to take questions.
This is Carol Lanza. Those people who are on the attendee list, raise their hand if they're interested in asking a question. People who are just on the telephone will have to unmute their phones on their own, and we'll look through and find unmuted telephones. Now, the problem is that we don't know who call-in user 4 on the telephone is, but we have one hand already raised here. It's Gina. So, Gina, if you unmute your phone, what is it, 6, star 6? Gina? Go ahead. Yes, we do.
My daughter is 6-year-old presently. She has had selective mutism. The onset occurred probably about the time I put her in preschool, around 6 years old. She's been at the same school through preschool. She's now in kindergarten. I held her back a year because of the selective mutism entering kindergarten. She's spoken one word in now 3 or 4 years. She goes to a speech therapist who is working with her. I'm really not sure what to do now. She has had an official diagnosis by a psychiatrist of selective mutism, but we have no, I'm running out of places to go. I hear that some of my parenting has probably attributed to that, since she is my youngest, and I tend to be, she was a very tiny preemie. She was only about 1.5 pounds, so I've been very overprotective of her. But what do I do from here? I mean, what kind of therapist do I need to look for?
I would look for a therapist who has experience in treating anxiety and hopefully selective mutism, although I recognize that's hard to find, especially because it seems like the symptoms have been ongoing for quite some time. You'd want somebody who is familiar with cases, that you've tried some things without success. And you'd look for somebody who knows how to walk you through some of these behavioral strategies.
She is at the point now where she will she had a video for one of the little girls she really likes in class, and shared the video with her. This was a huge step for her. Is this something that is positive, and should I go on from here, or is it something that, isn't that big of a deal?
No, that's a huge positive step. What I always recommend to families is once you find something that works, that the child is comfortable with, you have to take it and run with it. So you'd want to figure out what steps you could build on now that she's been willing to show that video to the friend. There a next step that would make sense for that particular friend? And also, are there other people who she'd be willing to make videos for, since that's a step she's been willing to take? There's no there's sort of magic formula or list of things to do with children, because it's so variable depending on what they find acceptable and what they're willing to try. So since she was willing to do that, I think that's huge, and you want to keep that in mind and see how you can be creative with that, and if there's next steps that would make sense.
Can I continue to do that, or will at some point be like, you can't do that forever?
Gina? At this point, I think that your question is a wonderful question, and I think that we might be a good thing for you to contact, if it's okay. Dr. Keaton has her email here, and perhaps she can give you some of your next steps, so that because it's 1 o'clock and we have some other people waiting to ask questions. And also, if you contact me, I will help you. Our office, we can help you maybe locate somebody to work with you, to give you some guidance.
Thank you so very much.
Okay, and thank you so much for sharing.
Thank you.
A quick question will the PowerPoint be available? Yes, I'll be sending that out to all our participants. Thank you. Kenneth McGill next, if you want to. Your phone. Go. Okay, go ahead.
My question, first of all, it was a wonderful presentation. Is there a connection between selective mutism and autism?
Let's see. I'm just responding to somebody's chat here real quick. Okay. Selective mutism and autism. Let's see. No. So a lot of children with diagnosis of autism do also meet criteria for selective mutism. But most kids with selective mutism don't meet criteria for autism. I know that just came across as very confusing. But what it means is, if you have a child with autism, the number of symptoms and behaviors to target in treatment. And one of those might be anxiety and lack of speech around certain people and situations. In selective mutism, usually you have children who are very high functioning, and they are developmentally similar to their peers. And the primary issue is this anxiety that shows itself by withholding speech. So I guess the main answer to your question is that many children who do have autism have comorbid anxiety, and they may withhold speech as a way to cope with that anxiety in some situations.
It benefits very well with the suggested cognitive behavioral. Thank you so much.
You're welcome.
Okay, do you have any other questions? Oh, I see any. Let me see if any call-in user. No, I don't see any questions. So So I have one more question. Okay. Two more. So go. You can your phone. Oh, okay, I'll read the question. Is it to befriend someone with selective mutism if there's a big age difference, like a mentor for a young child may have selective mutism? Is that a good thing?
Yes. So sometimes I work with teachers. Sometimes I have, if I have a child with selective mutism and I have the advantage of working with that child's teacher, some teachers want some tips on how to respond to the rest of the class when there's a child in the class who isn't talking. And one of the things I say is make sure the other kids know it's okay to continue to try to be the non-speaking child's friend. Because if they back off, then there's a lost opportunity there. But if they keep trying, then the child who's not speaking will likely come around at some point. So we say, like, don't abandon the child who's not talking, still make attempts to include them and to be their friend. So having said that, to answer this question, it's always a good idea to be there and to befriend somebody even if they have selective mutism, and to just be aware that they may not talk for quite some time, but that there may be other ways to communicate and have a quality relationship there.
Okay, thank you. And if you want to unmute your phone.
Okay.
Yes.
Okay, I have a young lady who has a 5-year-old, and she did follow me as far as getting her into counseling. Now, I'm not totally familiar with a therapist or a counselor, but when they do their intakes, is that something, because the 5-year-old really struggled with, she would bring out, she would totally, not all of what you discussed, some of the symptoms, and just when she's around new faces and all of that. She did say that school isn't saying that it's that. That just depends on children. When she went to the therapist, I'm not sure what type of testing. Is there specific testing? She did with her father when she was like 1 year old, and he was mainly the one that she would always be with as far as caring for her. So I think the therapist kind of has been getting her mom and through that.
Mm-hmm. Is your question, are there specific tests to diagnose selective mutism? Okay.
Yes.
There's a number of steps involved, and the assessment techniques are intended to both capture symptoms of selective mutism while ruling out other possible explanations of the symptoms or identify additional symptoms. So the tests usually include observing the child to see if the behavioral presentation is consistent with the child who has selective mutism. And there are certain checklists that individuals can complete. So, for example, there's one called the Selective Mutism Questionnaire. It's free and it's available to clinicians. So, it's easy to administer. There's one called the School Speak Questionnaire that a teacher can fill out, and that gives a sense of the frequency of speaking behaviors across contexts. And that would clue somebody in really quickly if in terms of speaking, the child meets the profile of somebody who has selective mutism. There's other checklists that are really helpful. For example, there's one called the Behavior Assessment System for Children, or BASC for short. And children who have selective mutism usually have peaks or elevations on specific subscales of that measure. So, for example, they have elevations on the withdrawal subscale and anxiety subscale. And then there are a bunch of other subscales where you could see if that means there's additional problems apart from anxiety and selective mutism going on. If there's a question about whether or not there's a communication disorder, like a specific language impairment of some kind, then a speech and language evaluation may be indicated. And there's lots of different ways, speech and language pathologists, there's lots of different options they have for that. But that's pretty much it. I mean, and it's a case-by-case basis. So it sounds like in this situation there was possibly a traumatic event. So there are other ways to assess for trauma. I will say, keep in mind, it's a big misconception that selective mutism is explained by a bad experience. That's not usually the case, although stressful and traumatic experiences should certainly be taken into account and could certainly be the cause, so to speak, but that's usually not the case. And so if you have a child who lost a parent at age 1, they're now 5, I would bet that there's some other explanations apart from that traumatic experience that the assessment would account for.
And I was just wondering if that would be something she could go back to the therapist and ask, as far as I don't know, as far as the selective mutism, because it is being introduced to me as well. So I know she doesn't have yet. Okay.
All right. Are there any other questions? Let's see. Call user 21 is unmuted. Don't you are, but if you've unmuted your phone and you'd like to ask a question, you go ahead and do that. Okay. All right. We've run over a little bit. We've kept Dr. Keaton past the promised 1 hour, and I know that this meant a lot to my who actually was one of the participants today. She was the one, she has a friend that she mentors who has selective mutism, and she felt that it was important that I locate an expert in the field, and I did my research and I found Dr. Keaton, and I think that Dr. Keaton certainly is an expert in this and has provided myself and my daughter and all of us who are on this call with information that we did not have, and with a new way of looking at a very I think it's more, but certainly more prevalent disorder than was previously recognized. And I thank Dr. Keaton for her time and for this information, for sharing with us. Thank you.
All right, thanks so much.
Thank you all for participating, and have holidays coming up. Take care now. Bye-bye.
Take